All right, Dr. Vikram and all our friends out there, thank you so much. Good evening from India. And I gather there are people who have joined in onto this webinar from different parts of the world. Welcome to one and all. I am Sanjit. I am the CEO of Miror, but just a humble servant. I actually follow the diktat of the rest of my team, which is all women oriented, and they are the true power of my team. So Mirror was, when I see so many people who have registered, who have signed up and are here today, it gives me immense pleasure because the whole idea of Mirror came about when we gathered that this whole topic of menopause and the 10 years before that, which is perimenopause, has no, there's no information. There was the narrative around that was not really clear. So that's what gave us the impetus of starting Mirror, with the intention of talking more about it. So webinars like this and very interesting and contentious topics like HRT is exactly why we at Mirror exist, is to bring people to express their questions so that we have subject matter experts, subject matter experts to actually talk about HRT and other contentious issues. So thank you, everybody. So let me start by giving a quick introduction to Dr. Vikram Talaulikar, MBBS, MD, FRCOG, PhD consultant, endocrinologist, a specialist at the reproductive medicine unit of the University College London Hospital, the NHS Trust, an honorary associate professor in women's health at the University College London, member of the International Menopause Society, European Menopause Society, British Menopause Society, as well as the Andropause Society. His clinical interests include premature menopause and menopause, runs a very busy menopause and premature ovarian insufficiency clinic at University College London, and also is a certified menopause specialist and a trainer for special menopause skills and BMS principles and practice of menopause care. For me at Mirror, it's so much pleasure to be a guy talking about it. And it gives me even more pleasure to introduce to another a man whom I look up to, who was such a guiding factor when I started this over a year ago. He had the nicest words of encouragement. Thank you, Dr. Vikram. The stage is yours. Thank you.
Thank you, Sanjit. Thank you very much for the kind introduction. But also thank you for having webinars like this. I think you mentioned to me some time ago, people often go, you're a man. Why are you working in this area, which is really women's health? But I think it's important that everyone comes together to work in this area, whether it's women, it's men, it's everyone in the society, community. We all ought to do our best for women in terms of general women's health, but also specifically women who are going through perimenopause, menopause, and may not have it easy. There can be times when this transition can be quite difficult. So I think understanding this phase better, what can we do for them? Everyone has their role to play in the community. So hopefully in today's webinar, we'll do justice to that. We'll go through a little bit about what happens during menopause, but the focus really will be the hormone replacement therapy. Does everyone need it? What is it? Why there is so much controversy around it? So we'll look into all that in the next 25-30 minutes. And then I really want to get the floor open for questions. I'm sure, Sanjit, you've already had questions from your participants. But if there are other questions which we don't cover in the 20 minutes, then of course we will try to give you time to get your questions in. And then we'll try to answer each one of them as much as possible before we end this webinar. So I'm going to try and share my slides. So if I go to share now, and I'm going to share my screen. Hopefully you will be able to see my screen. Do shout, Sanjit, if you can see my screen.
I can see your screen, yes.
Perfect. So I'll go to the slideshow right from beginning. And so perimenopause, menopause, hormone replacement therapy. Let's start with some of the basics. That's my intro. Sanjit has already done that. So let's go to the topic, which is the stages during journey towards menopause. The reason I'm going through some of these basic slides is because when we talk about HRT or hormone replacement therapy, we will be referring to some of these changes that happen physiologically during menopause. So premenopause is a phase before any hormonal changes happen. This is when most women will be having a regular menstrual cycle, generally a monthly bleed. Their blood levels of estrogen, progesterone, as well as the FSH, LH will be all within normal range. They won't be having symptoms of estrogen deficiency. The first stage that starts the journey towards menopause is the perimenopause. This is when hormones fluctuate. Estrogen levels go up and down, FSH, LH blood levels go up and down. And of course, symptoms start at this point. It could be variability in the periods, irregularity of periods. Periods can come close or they can spread out and the gap between periods will increase. This is also the stage when symptoms such as some mood fluctuations, hot flushes, some sort of vaginal dryness, bladder issues, weight gain may present themselves. And this perimenopause usually will last for around 2 to 5 years between the age of 40 to 50. Now, it's more so in the white women, we see it around 45, 50. But in Southeast Asian women, Indian population, this might happen in late 30s or early 40s. And it could be more than 5 years, up to 10 years of perimenopause, the hormone fluctuations before menopause happens. Menopause is a final stage when periods stop. After all those fluctuations in hormones, eventually ovaries are making very little estrogen, no progesterone, so the periods stop. And it's a retrospective diagnosis. You have to wait for periods to stop for 1 year before you can say somebody has gone through menopause. And finally, of course, the post-menopause phase comes. This is 1 year since the periods have stopped, right until the end of life. Now, this could be 10, 20, 30, 40 years of a woman's life. And that's why we should be giving attention to this phase, because we want women, those 20, 30, 40 postmenopausal years, to live a good quality of life, protect their long-term bone, heart, brain, and metabolic health. So that's why the focus on menopause in the recent times. Why menopause happens? Menopause happens because all women are born with a set number of eggs. And you can see right at the time of birth, there are millions of eggs in both the ovaries. And these eggs get used up over a period of time throughout life. And so by the time woman reaches the age of around 45 or 50, she will have very few eggs left. All those millions of eggs over the years have been used up, either through ovulation or in the background. And there are only 25,000 eggs left in the end after 40s, and only about 1,000 left nearly when the woman gets to 50. Once that happens, the eggs have been used up, the ovaries will not produce more hormones, estrogen, progesterone, and they'll be slowing off the testosterone. And that's what stops periods and causes some of the hormone-related symptoms. That's a graph on the left side showing you the actual hormone fluctuations. So before menopause happens, between the ages of 0 to 40, you can see lots of estrogen in the blood. Thereafter, perimenopause happens around 40, 45. So the estrogen levels go up and down, causing symptoms. Once the estrogen levels have really plummeted, very little estrogen is coming from the ovaries. You will have menopause, no more periods. But you can see the symptoms will be quite significant around menopause and post-menopause, whoever gets the symptoms. Estrogen, FSH, LH levels fluctuate. We saw during perimenopause, progesterone levels drop as there are no more ovulations happening. There's an interesting thing about testosterone, which is slightly different from estrogen, progesterone. Testosterone starts dropping even in 30s. So even after the age of 30, there's a gradual fall in the testosterone levels in women. And that tends to kind of keep falling during perimenopause and plateaus after menopause. So some women who are very sensitive to the lack of this hormone may have testosterone lack symptoms, and they may overlap with the lack of estrogen during menopause. When does it happen? For majority of women in Europe and North America, it's at 51. And early menopause is said to be when it happens between 40 to 45. That's supposed to be 40 to 45, not 45 to 50. This was an earlier concept. And then premature menopause is when it happens below the age of 40, which happens in 1 to 2%. So remember, 90% of women will have it somewhere around 50, so between 45 to 55. 10% will have it early, below the age of 45, 40 to 45. And premature menopause is about 1 to 2% when it happens below the age of 40. The average age in India right now is thought to be 46.5. So you can see there is so much ethnic difference. In the Western world, it's 51, which is average. In India, Southeast Asia, some of the Afro-Caribbean countries, it's 46 to 47, which is 5 years earlier menopause than the average menopause in the Western world. And that is significant because you're going to have 5 less years of hormones, and that may have a significant impact on long-term bone, heart, or metabolic health. So how many women experience symptoms? About 80% of all women will experience some or other menopausal symptoms. And there's a marked variation. There may be women who have no symptoms at all or very minimal symptoms, but you could also have women who can have very severe and debilitating symptoms. So there's a lot of variation in how frequently these symptoms happen, who gets them, and how long do they last. For many women, they will just last 2-3 years. On an average, they will last for 5 to 7 years for most. But for about 10-20%, the symptoms may go on for up to 10, 15, 20 years into their 60s and 70s. So everyone is different. Because someone has had an easy menopause doesn't mean the other person will. And also, if someone has had lots of symptoms and a difficult menopause, it doesn't mean everyone has it and everyone has to take HRT. There is lots of individual variation. Now, some women may have menopause because of medical reasons, cancer treatments, chemotherapy, radiotherapy, immune treatments. They can have surgical menopause, often at the time of hysterectomy for heavy bleeding or fibroids, ovaries are removed. That causes overnight surgical menopause. There can be ovarian tumors or cyst or endometriosis that can cause surgical menopause. These kinds of menopause can be quite severe because they happen acutely. You don't get the time that happens with natural menopause, where there's a gradual decline in hormones. Medical or surgical menopause can happen in weeks or days, and it's quite abrupt. So it's really important these women are supported because they will have quite a lot of symptoms within a short period of time, and they can be quite persistent. What are the symptoms of menopause transition? The lack of hormones, the lack of estrogen, the lack of progesterone, and slowing down of testosterone will give rise to a variety of symptoms. And again, some may have none, others may have multiple symptoms from head to toe. So it can present as headaches or migraines, brain fogging, not being able to recollect a word, or not being able to give confident presentations because you're missing, not being able to concentrate and focus at work like before. That's called as a brain fogging. Low energy, fatigue tends to set in for many women. Hot flushes, night sweats, temperature sensation of coming out with lots of sweating and chills. Sleep problems, again, quality of sleep at night goes down. Frequent waking episodes may happen. Those are all the typical symptoms that we describe. Irregular periods can be a sign of perimenopause, and of course, at menopause, the periods will stop. The two I have highlighted in red circles are often not talked about, but low mood, anxiety, heightened anxiety, worrying about things, palpitations, depressive thoughts, these are again not talked about symptoms of perimenopause and menopause. Similarly, dry skin, dry eyes, itchiness of skin, crawling sensation under the skin, joint pains or aches in muscles and joints all over the body can be some of the physical symptoms. Local symptoms, pelvic symptoms can be vaginal dryness, painful sex, lowering of libido, not having sexual desire. Again, these are very relevant more so for women who may have premature menopause, surgical menopause, and often not talked about because of the embarrassment that these symptoms may create. Besides this, there are long-term changes happening. It's not just the symptoms and the quality of life. There are changes because of menopause happening in the lipids, the cholesterol and the LDL and the HDL. So the good cholesterols go down and the bad cholesterol increases because estrogen keeps the good cholesterol high. But once it's gone during menopause, usually the bad cholesterol will start rising. The body fat distribution changes. Often women report fat around the middle. And that's again redistribution of body fat because of lack of estrogen. Increase in blood pressure is typically happening in early menopause for many women because the protective effect of estrogen on blood vessels is gone. This is also the time when insulin resistance comes in. Many women will be diagnosed with pre-diabetes or diabetes, and insulin function is usually helped by estrogen. So insulin resistance becomes part of perimenopause, menopause, and often contributes to further weight gain. And finally, there'll be changes to the blood clotting, which can increase your risk of blood clotting after 50s and 60s. So how do we address symptoms? We've got a number of options trying to address symptoms, make it less problematic for the woman, improve quality of life. But at the same time, some of them may also have benefit for long-term health. So let's look at some of these one by one. So lifestyle modification, changes at workplace to make it better, nutrition or self-help interventions. There are alternative therapies, there are non-HRT medications, and finally, we talk about HRT. Do you always need blood tests to confirm that you have menopause? The answer is no. It's symptoms. If you're above the age of 45 and if you have menopausal symptoms, you do not need to have blood tests. Blood tests may be useful if you have premature or early menopause below the age of 45, but certainly after that, you don't need to have blood tests to be prescribed HRT or be offered any non-HRT medication. Is testing always required to start any treatment? The answer is no. And is testing required to monitor or change HRT? Again, the answer is no, because hormones fluctuate in your bloods. There are many factors which affect levels of hormones in the blood, and one should stay away from blood hormone testing for management of menopause. So what's available? Lifestyle intervention. So we want reduction of caffeine because caffeine can trigger some of the menopause symptoms. Healthy diet is really key. Less amount of alcohol consumption helps with the symptoms and the flushes and the long-term health. Mediterranean type of diet is what we often recommend for most women going through perimenopause, menopause. So lots of pulses, cereals, nuts, legumes, fish, all those kind of healthy Mediterranean foods. Exercise is key. So things like yoga, Pilates, but weight-bearing exercise. Running, brisk walking, jogging would be really good for bones and for general metabolism. At least 30 minutes of exercise every day, 5 times a week. Several layers of light clothing may help. If there are lots of flushes happening during the daytime, wearing layers of clothing which you can take off if required. Vitamin D is something we recommend as supplement. That's the only vitamin usually needed to keep your bones healthy. Calcium, protein-rich food. This is again for your bones and the muscles because protein and calcium in food is the best way to take it. There are complementary therapies, acupuncture, homeopathy, herbal treatments. We don't tend to recommend the complementary therapies because the evidence about long-term efficacy, safety is little. So we don't often medically recommend them. Psychological therapies can be useful, such as relaxation, cognitive behavioral therapy, mindfulness, hypnosis. These are very useful for anxiety, flushes, or sweats, or sleep issues. So if someone doesn't want to have HRT, lifestyle interventions and psychological therapies are useful for improving quality of life. What else non-hormonal is available? There are some treatments which we offer women who've had cancer, for example, breast cancer or gynecological cancer, which can be hormone sensitive, or they've had blood clots in the past and they can't take hormones. For those women, non-hormonal options do exist, such as SSRI medication, gabapentin, clonidine, and there's a new medication approved in the UK this year, which is called NK3 receptor antagonist. It's a non-hormonal treatment for hot flushes and quite effective. I'm not going to go into details of all these because we have short time and it's mainly about HRT, but just to tell you there are non-hormonal options when HRT may not be desired or cannot be used. So we come to what is HRT? What is hormone replacement therapy? Why there is so much controversy and who benefits from it? It's replacing estrogen, progesterone, and in some women also adding testosterone. That's simply replacement of the 2 or 3 key hormones is called the HRT. Why is there so much controversy and what has happened over the years in terms of evolution of HRT? So HRT was very popular right from 1950s when it first started getting used. In the 60s, 70s, 80s, 90s, in the last century, HRT was quite widely used. Initially, it was estrogen only. Then people realized you have to take estrogen, progesterone together. So from 80s, 90s, it was very popular for menopausal symptoms as well as helping improve future health. There were two big studies that got published around 2002, 2003. One was the WHI study, which was a randomized trial in the US, and there was a UK million women study, which was an observational trial or study in the UK. And both these studies came up with very negative results for HRT. Often the press headlines said HRT causes stroke, HRT causes breast cancer, HRT causes heart disease. And so everybody got panicked. The HRT prescriptions dropped. People started not using HRT as often. There was panic in women, but also in healthcare professionals, and it still exists till date. A lot of healthcare professionals still are not confident prescribing HRT. They hesitate about prescribing HRT when it would be indicated. That's because of these traditional studies. But NICE in UK looked at all these studies in detail in 2015. So this is National Institute for Healthcare Excellence in UK. And in 2015, they looked at all these data in 2002, 2003, but also further studies which had happened since then. And they realized that those risks had been exaggerated because actually some of the participants in those studies already had medical issues, and sometimes they were over the age of 60. This is when we don't start HRT. It's much earlier, 45, 50. This is when we start HRT. So the risks had been exaggerated, and the modern HRT is much more safer, doesn't carry the same risk. So the NICE guidelines said most women's benefits from HRT for health outweigh the risk, and it should be offered to more women. And that's how a little bit of menopause revolution happened, and we are able to now offer HRT to more women, which is much more safer than the traditional HRTs that were used at the time. So these are some of the tabloid headlines at the time, damning HRT in terms of risks of stroke, cancers. And of course, you can see what the effect of that WHI study on the prescribing was. Around 2002, 2003, you can see the crash in the prescriptions. A lot of women were left without access to HRT. And you can see what happens. The yellow line is antidepressant. The blue line is the actual HRT prescription. As the HRT prescriptions came down, women who were symptomatic, who had difficult menopause, had nowhere to go. So they had to rely on antidepressants to take care of their symptoms. So that prescribing increased. So it's important to know that the modern HRT is different from the ones that were there at the time, and it has much more benefits than risk. And that was the conclusion from the NICE. HRT is not a danger, benefits outweigh risk for most women. So let's look at the three hormones. What are their benefits? What are their side effects? What are the risks? And what would be the benefit-risk ratio? The first hormone is estrogen. This is the main hormone in HRT. It gets rid of most of the menopausal symptoms, improves the flushes, improves sleep, better energy, better mood. It usually takes care of the brain fogging. And so usually that's the main hormone that is part of the HRT. It does have some additional benefits. For example, it protects the bones. It prevents osteoporosis, which is a problem during menopause for some women. It protects heart. So if you start HRT within the first 10 years of menopause, it protects heart and prevents heart attacks in 50s, 60s, 70s. It improves memory cognition. So the brain fogging will be much better. It improves metabolism. It reduces the risk of diabetes because, as we saw, estrogen helps insulin function. If somebody takes HRT estrogen, what are the minor side effects that you can have in the first 2 to 3 weeks? It's usually headaches. You can get a bit of breast tenderness, and you can get a bit of nausea. So these are typically for the first 3 to 4 weeks after starting HRT, after which these side effects will disappear. Progesterone is the second hormone that's combined with estrogen. We call it the necessary hormone because any woman who still has a uterus, any woman who still has a womb, will need to combine progesterone with estrogen because estrogen thickens the womb lining. The progesterone prevents it from becoming thicker and cancerous. That's why both are combined to eliminate the risk of womb cancer. So Progesterone has some side effects, for example, bloating, mood changes, sometimes a bit of fluid retention. And these again will pass with time. And it can help with hot flushes, it can help with sleep, it has some symptomatic benefits, but the main thing is to protect the lining of the womb. Any little breast cancer risk that comes from the HRT comes from the progesterone. The estrogen usually is not the culprit, it's the progesterone combined with estrogen that brings in the slight risk of breast cancer. So women who have a womb will take both hormones. Women who have had a hysterectomy just need estrogen, they don't need progesterone. The good news is that any side effects or risk from progesterone can be minimized. You have something called as a natural body identical progesterone, which is very safe and effective progesterone, which can be combined with estrogen, which minimizes any side effects. Or progesterone can also be given as a Mirena coil, which is a coil inserted into the uterus. Again, this can be another way of combining progesterone with estrogen. Finally, we have the third hormone, testosterone. There's a lot of controversy about it, but we call it the neglected hormone because it's not a male hormone. Women produce lots of testosterone on a daily basis. It improves libido, improves sexual desire, sexual function. So some women, especially after surgical menopause, operation to remove ovaries, may have a sudden drop in their testosterone and often find the effects of lack of testosterone. And in those situations, testosterone can be replaced with efficacy. Similarly, women who use HRT and still feel low libido, where we've ruled out any other causes, then again, testosterone can be quite useful for libido, energy, muscle, and bone strength. There are various ways one can take HRT, whether it's tablets, capsules, there are patches on the skin, gels you can rub into the skin, or a spray which you can spray on your skin. There are subcutaneous implants which can be inserted under the fat beneath the skin. There are vaginal creams and there are vaginal pessaries or tablets of estrogen. And of course, there is the Mirena progesterone intrauterine coil. So many options to choose from. What's the best that we recommend? Certainly for estrogen, we recommend the patches, gels, implants. They are the best ones, or the spray, because they go through the skin. You don't have to swallow a tablet. When you swallow a tablet of estrogen, it can go through the liver and increase your blood clotting risk. But that does not happen with patches, gels, or spray. So it's one of the safest way of taking estrogen with no risk of blood clotting. With the progesterone, we often recommend the oral micronized progesterone, the body identical progesterone, or the Mirena coil, again, because they do not increase risk of blood clotting and they have minimal side effects. What about vaginal estrogen? Vaginal estrogen creams or pessaries or tablets are very effective. They can be treating the vaginal dryness, any pain, any irritation. They keep the urinary tract infections away, and they can be used as long as required because the vaginal estrogens are not absorbed in the rest of the body. So they are very safe. Even if women have had cancer, such as breast cancer, in most women, you'll be completely fine to use vaginal estrogen because it's localized use of hormone, which is not getting into the rest of the body. When do you choose a bleed or a bleed-free HRT? Women who's just gone through menopause will often be given a cyclical bleed HRT, while somebody who's been menopausal for more than a year doesn't have to have bleeds and go for a bleed-free continuous HRT. So last bit is what are the risks? So we've looked at the benefits of HRT, the benefits for quality of life, for better functioning. We've looked at the bone, the heart, the metabolism, the weight benefits. What are the risks that we balance this against? So often the worry is, will HRT give me a blood clot? Will HRT cause me breast cancer? And there are fallacies with the information out there. So let's look at the blood clotting. We know that oral forms of HRT, such as the tablets which were usually given in the past, can increase your risk of blood clotting. The overall risk is very tiny. The risk is like 5 in 1,000 or less. It's absolutely small risk. And it's a lot lower than the risk you have in pregnancy or when you take the contraceptive pill. So for example, many healthcare professionals or doctors will prescribe the pill easily. The progesterone or the contraceptive pill is given easily. Nobody talks about risk of blood clotting, but when it comes to HRT, the risk is actually smaller, but often people will be worried to talk about HRT and blood clotting. the risk is lower than a pill or a pregnancy. But even if you want to eliminate that little bit of risk, then if you use HRT in the form of patches, gel, or spray, there's no increase in risk. There's no risk of blood clotting when you use it with the patches, gels, or spray. What about stroke? The same thing applies. Women's risk of stroke only can increase slightly if you take oral HRT, but it does not increase with the modern patches, gels, or sprays of estrogen, or the coil or the micronized progesterone that we use. It doesn't increase your risk of stroke. Finally, coming to breast cancer. Now let's look at different life factors and look at the risk in terms of HRT prescription. So here is a comparison. If you look at, say, 1,000 women who are going through menopause between 50 to 59, so typical menopausal age, they're having menopausal symptoms, and you follow them up for 5 years. So all those 1,000 women, we're going to follow them up for 5 years and see how many of those 1,000 get a diagnosis of breast cancer. So if you have women who are not taking any form of HRT, about 23 women will develop a diagnosis of breast cancer over 5 years. Now let's compare it to women who have HRT. If you give HRT to these 1,000 women for 5 years, you get 4 additional women who will have a diagnosis of breast cancer. So that's 4 in 1,000 women over 5 years. Very, very, very small absolute risk, but that's 4 in 1,000. Now, look what happens if they take estrogen only. So if they've had a hysterectomy and they're only taking estrogen, not the combined estrogen progesterone, they actually have a lower risk of breast cancer. So people often say estrogen HRT causes breast cancer. That's not true. The randomized trials show that you have a lower risk of breast cancer with estrogen only HRT, less 4 cases. What about those who take the pill? So most women have used the contraceptive pill in their life. It's exactly the same risk as the HRT, but no one often talks about the risk of breast cancer with the contraceptive pill. Everyone talks about the HRT, but you can see the risk is exactly the same. If you look at women who drink 2 or more units of alcohol a day, the risk is bigger than HRT. Women who smoke will have a 3 in 1,000 risk. Look at the weight. If you're overweight or you're obese, your risk is 24 extra women in 1,000. That's way more than what HRT will cause. But often people will not talk about weight or BMI or the effect of poor diet. That's far more risky than HRT. And exercise always helps. So if you take the 30 minutes daily exercise, you can cut down your risk of breast cancer by 7 less per 1,000. So HRT actually is not different from many of the lifestyle factors, but it just keeps getting the bad name, and people often hesitate about breast cancer, even though there may be good benefits with HRT. And that's again a summary of what I talked on the last slide. So you can see the BMI has the biggest risk for breast cancer and the alcohol compared to HRT and the smoking. So risk of breast cancer from HRT does not apply to women who have premature or early menopause. So this is very important again. Women who go through menopause below 40, below 45, very young to go through menopause. Even if you give HRT till the age of 50, there is no increase in the risk of breast cancer. It's only after 50 when that small 5 in 1,000 risk of breast cancer applies. A lot of young women are denied HRT below the age of 50 because you will get breast cancer. That's not true. If you have premature or early menopause, you can safely take HRT till 50 when there will not be an increased risk from HRT. So how long do women typically take HRT? So they start in perimenopause and they continue for menopause for 5 or 10 years. Is there an upper age limit? No. If you have symptoms, if you want to continue HRT, you can continue in your 60s and 70s. As long as benefits are there and they outweigh the risk, we continue. It's an individual choice. Most women use it for 5 to 10 years and then they stop. They don't tend to have symptoms coming back. So overall, the message is that menopause is an opportunity. This is an opportunity in your 40s and 50s to make changes to your lifestyle, diet, exercise, sleep hygiene, meditation, stress management. This will help optimize health, prevent chronic disease. This is the time to concentrate on bone health, metabolic health, cardiac health. If you're symptomatic, don't suffer with symptoms. You have a good option with HRT, which can help for 5 or 10 years or longer. Not everyone needs HRT, but it's important not to suffer just because of theoretical fears or myths about HRT, which continue from the time of WHI study. So a lot has changed in the past 2 decades. Modern HRT is much more safer. It's body identical. Quality of life, bone, heart benefits outweigh the risk from HRT for most menopausal women. But it's important to do it individualized. So see your GP, see your doctor, see your gynecologist, see your healthcare professional who you trust. So you can have a discussion about your own benefits and risk, and then make that informed decision if you wish to take the HRT. That's all from my side, and we'll hopefully open the floor for questions.
Wow, doctor, this was amazing. I mean, your last couple of slides was very interesting to read, that menopause, perimenopause is actually an opportunity to make changes in your lifestyle, and I think that's one message that we at Mirror also tell all our women in our community and everyone we speak to, is that actually don't look at this as a stage where everything is lost, because women typically have spent most of their lives taking care of others, and I think it's time they take care of themselves first. Just lending adage to what the announcement in the planes say, that first put the oxygen mask on yourself. If you can breathe well, so will the others around you. So I think that's a great way to end it. And there are so many questions who have already started coming in. You answered a lot of questions, but so what is the advice that you would give typically to a woman who is just considering starting HRT? Now she's scared, she's got a lot of negative, thanks to the WHI study, people are saying, don't be stupid over my dead body, don't you dare have it. What was the advice that you would give a young woman who's thinking of taking HRT?
So the advice would be HRT is the best form of treatment if you're having symptoms of menopause, which are driving your quality of life low. So if you're struggling in your menopause, perimenopause, having lots of symptoms, they're driving your quality of life low, then no need to suffer. HRT in the modern way, given through the skin for estrogen, combined with the appropriate progesterone, is safe. The benefits for your quality of life, for your bones, for your heart will outweigh any small risk of breast cancer. That risk is very low. And again, that's a discussion you have with your doctor, but most women will be safely able to have HRT for 5 to 10 years and the risk will be low. So my advice would be, look at the evidence, look at how much the menopause is impacting you, and consider HRT as one of the options.
Thank you, doctor. Another question that has been asked is, menopause is such a natural phase of my life. Why do I need to interfere with that natural menopause phase?
Very good question. You don't have to interfere at all. What you have to do is optimize your health. So if you can optimize your health in the terms of lifestyle, taking care of your bones, taking care of your heart, because remember, although it's a natural phase of life, the estrogen level will go down after menopause. And that means your bones are starting to get weaker. That means your heart is starting to get problems. Your blood vessels are starting to get problems. That's how physiology is. Estrogen levels drop, atherosclerosis increases, bone fragility increases. So if you're effectively tackling that with good lifestyle, eating the right things, exercise regularly, you don't have to consider HRT. But HRT is for symptom. Some women will do all that, optimize their lifestyle, but still will have difficult symptoms, which really draw them down during this phase. That's when HRT comes in. Is not only it will improve your symptoms, give you a decent quality of life until the symptoms go away in 5 or 10 years, but it will then add benefits over and above your natural lifestyle. So we don't consider it as something that's going to change the course of your menopause or include in the natural phase. It is just a support if you're finding it difficult to carry on day to day with your menopause symptoms and also have additional benefits for your long-term health. That's when you consider it as an extra add-on, not something that replaces your natural good lifestyle.
Thank you, doctor. Another lady has asked us, I mean, this was covered in your presentation, but when should I start? How long can I take? When should I stop?
So you can start HRT at any point you start experiencing symptoms. Because as I said, HRT is a treatment for unpleasant symptoms of menopause, which start bothering you, which start causing trouble. So you can start as soon as you experience that during perimenopause or menopause, usually in your late 40s or early 40s for some. So the moment you start seeing that the hormones are changing and they're causing you symptoms, that's when you consider starting. The earlier you start HRT, the better for long-term health. And then you continue depending on how long your symptoms last. So as I said, most women will continue until 55, 60 and then come off. Others might stop much earlier. Some might still carry on in their 60s and 70s because they do have symptoms coming back when they stop HRT. Everyone is different.
Thank you, doctor. There are questions on bioidentical, body identical, there's different interpretations. Can you just throw more light on that, doctor?
So there are two kinds of HRT we talk about. One is body identical, which I've mentioned in my presentation. So body identical simply means estrogen and progesterone, which are similar to the ones that the body produces, the ovaries produce. And these are usually plant-based, usually obtained from yams and soy. And these are regulated. They're produced by pharmaceutical companies who have to do trials and establish the safety and the efficacy of these medications. So on the NHS worldwide, across menopause clinics, usually you will find that body identical HRT is used. It's very safe and regulated. What we don't recommend using right now is bioidentical. So this is a compounded HRT. Every high street clinic can make their own estrogen progesterone combinations from different plant sources. We don't have regulation on this. We don't have long-term trials and safety data. So bioidentical HRT, which is usually popular in countries like US and a few others, we don't recommend them as part of the National Health Service, or also most of the guidelines do not recommend bioidentical products because of lack of long-term safety data.
Thank you. Thank you, doctor. Another question is, how does HRT compare to non-hormonal treatments in terms of effectiveness and safety?
It's not as, so HRT is much more effective. The non-HRT options are not as effective, which is why HRT is thought to be the most efficacious medical intervention for menopausal symptoms. But of course, they have their role because remember, not everyone wishes to take HRT. And some women may have medical problems like blood clotting or hormone-sensitive cancers. They can't take HRT because that would increase their risk. In those situations, some of those non-HRT medications I mentioned would be quite useful to reduce symptoms, reduce flushes, sweats, ensure better sleep. So they have their role in women who would not want to take HRT.
Thank you, doctor. So question is, I'm already 52, but just starting to have changes in my periods and feeling some joint pain. Would it be safe to start this at my age?
Absolutely. The simple answer is yes. If you're 52, seeing changes to your periods, that's perimenopause. Your estrogen levels are fluctuating. Some days are good, some days are not good. And you will be symptomatic, like the joint pains. And you might see few more symptoms appearing in the next few months or years. This would be a good time to consider HRT besides non-HRT lifestyle changes.
Thank you, doctor. Another lady asked, what if my BMI is less? Can I take HRT?
Yes, absolutely, yes. For any BMI, transdermal HRT and the progestogens we mentioned are pretty safe. You don't have to worry about BMI to consider HRT. Very high BMIs, sometimes we say it's really important to lose weight with good diet, exercise, improving exercise regimes and putting in effort to lose weight. But low BMI is certainly not an issue.
Thank you, doctor. Another lady asks, what is your opinion about plant-based phytoestrogens and their efficacy?
So plant-based phytoestrogens are basically very weak estrogenic compounds, which are found in things like soy, tofu, few other pulses, legumes, and cereals, which have plant-like action, estrogen-like action. These have 1,000th of an action of estrogen. So you can imagine how weak it is. almost 1,000th the action of estrogen. Most women who increase phytoestrogen do not find any change in their symptoms. So there are small trials, observational studies looking at increased phytoestrogen diet and relief from menopause symptoms. And some women report improvement in the first 6 months, but it doesn't last long. So we don't recommend phytoestrogens as a treatment because it's very weak. It certainly doesn't have any downsides. So you can increase soya tofu consumption and the pulses in the cereal. But if you have menopausal symptoms which are moderate to severe, it's unlikely to help in that situation.
Thank you, doctor. Question. I have just turned 50. I've been perimenopausal for over 5 years. I have a lot of symptoms. I have a womb. Can I go for HRT? Which one would you recommend?
I can't give personal medical recommendation because it's a webinar. I would need to know a lot more medical information before I recommend anything, but it's a good question. It's a typical situation when you're at 50, you're now heading towards menopause, having symptoms, you still have a uterus. One would recommend estrogen with progesterone. If it's estrogen, it's going to be transdermal, patch gel or spray form. And then you can combine that with a naturally progesterone or a Mirena coil. So there are various combinations available. You can talk to your doctor or gynecologist who will be able to advise you on that.
Thank you, doctor. Another question. I am 46 years old, and since 40, I was diagnosed with perimenopause. The recent test didn't show urine infection. My fibroids are not pushing the bladder. So want to know if low levels of hormones are the cause of frequent urination. My gyno rejected to a surgery to remove fibroids and doesn't want to put me on HRT because it was said that estrogen dose can affect negativity in my fibroids.
So again, I don't have a lot of medical information here, so I'm not providing medical advice. But as a principle, estrogen progesterone combination HRT does not usually cause any significant increase in fibroid size. People often think that HRT will grow the fibroids. Occasionally, yes, but for majority of individuals, there is very little change in the fibroid size. So you can safely take HRT if you're experiencing menopause symptoms. With the bladder, often urgency of bladder, urinary symptoms can be a sign of lack of estrogen during perimenopause or menopause. And sometimes vaginal estrogens will help with that. But again, as I said, it's a limited medical information. You can safely take HRT, even if you have not had an operation for your fibroids, if you're suffering from menopausal symptoms.
I was on mute, sorry. So one question is, how does genetics influence the suitability of HRT for an individual?
We don't know the answer to that. Genetics plays a part in when you have menopause because the number of eggs you're born with depends on your genetics, your ethnicity. And so you might be predisposed to have premature or early menopause based on your genetics. In terms of suitability for HRT, there is nothing that we know about the link between genetics and what HRT particularly will be suitable for a person. What we determine the suitability of HRT is based on the clinical experience we have and the trials we've done. We know that certain estrogens and progestrogens are safer for certain individuals based on their medical history, and that's how we prescribe. We don't have a link between genetics and the type of HRT.
Thanks, doctor. Another question. Hello, I started 3 weeks ago with HRT, estrogen gel and progesterone pill. Symptoms are a little better, still very low energy levels. How long will it take to actually help me?
It does take 3 to 6 months. So you're very early in the starting phase of the HRT. Remember that you often in perimenopause, menopause, you've been without hormones for a significant number of months or years. The hormone levels have been either fluctuating, low, or absent. So it does take your time to come back to having hormones, recognizing you're getting your hormones back. Also, the dose will depend from person to person. So what they may have started you on is the lowest effective dose to start with, and that's the right way to do it. Now, in next 3 months or 6 months, keep a diary of your symptoms, see when you bleed, and that will give your doctor enough information to know, is this the right form for you? Is this the right dose for you. They may be able to go up the dose if your symptoms are still not fully controlled. Equally, remember that it can take 3 to 6 months. So by the time you get to 6 months, you might find your energy levels have also improved. So early stages, give it a little bit more time.
Thank you, doctor. I am in surgical menopause and 34 years old. I'm having lots of symptoms. My doctor recommends evening primrose oil, vitamin B and C. How effective is that in comparison to HRT?
So I don't know more medical details, including your age. Did you say 34?
She said 34, yes.
34 is very young to go through menopause, especially if you've gone through surgical menopause and removal of ovaries. That is really probably depriving you of hormones right now. There is no doubt that you need to have hormone replacement therapy unless there is something else in your history, which I don't know. But you would be the one person who would need HRT, estrogen, progesterone. The evening primrose oil and the vitamins will not replace HRT. You need HRT for your bones, for your heart, for your brain until you get to 50, and you should not have any increased risk of cancers or blood clots from them. So please do check with your doctor, maybe have a second opinion, because HRT is really recommended under the age of 45.
Thank you, doctor. So, I mean, there are some technical questions, and you said you cannot give medical advice on a webinar. So is Mirena coil, I think it says LNG-IUS, similar to progesterone plus estrogen Mirena?
So remember, out of the progestrogens that we talk about combining with estrogen, the best ones are natural progesterone and the dihydrogesterone. Those two are the best ones, most breast-friendly and least risk of blood clotting. Next comes the LNG-IUS, which is the Mirena coil. This has a synthetic progestrogen, not a natural one, but it's local in the womb. So that is the next best one. And then come the older progestrogen, the Provera, the norethisterone, which we usually no longer use now. So if you have a choice to use one of these, the natural progesterone or dihydrogesterone will be the best one. And then the coil comes next.
Thank you, doctor. A lady saw my gynec the other day who said patches are not available in India. I've had symptoms since my 40s, but they are lesser now, except for bad sleep and bloating. What should I do?
So again, if you're thinking of treatment with the hormone replacement therapy, because it certainly improves sleep if it's linked to the perimenopause, menopause, you could consider alternative forms of HRT. I do have people who travel all the way from India to UK simply because there are not many hormone preparations available in India. I know that it's now possible to get a gel. There are many women being prescribed the estrogen gel. And I think some places also patches are available, but it's difficult to obtain them across in different states. So all I would say is find out locally what is available, either a gel, spray, or patches of estrogen. If you have access to them, that's good. Otherwise, probably you might need to go to a state or a clinic which has access to these forms of HRT. Unfortunately, lack of options of HRT in India is a concern. A lot of people say the same when they see me, that there are not enough preparations available. Hopefully that will change in future. And Sanjeet might want to look into this, something that in future will help a lot of people to get more HRT products available.
Thank you, doctor. With your help and guidance, yes. So another question is, hello. So I'm experiencing early menopause, in brackets, low estrogen found in blood tests, brackets closed, due to hysterectomy surgery that was done for medical purposes. Thankfully, all was benign. My uterus and one of my fallopian tubes were removed. I still have my ovaries, but on my maternal side, we have history of breast and ovarian cancers. So do you still recommend HRT?
Yes. The simple answer is if you've had early menopause, which means below the age of 45, and you've had a hysterectomy, even if you keep the ovaries, remember that you tend to have an earlier menopause after a hysterectomy. So the uterus is removed, causes changes to the blood circulation. And even if the ovaries were left, you tend to go through menopause earlier within a few years after a hysterectomy. So that means that you've been deprived of hormones earlier. You can safely use HRT until the age of 50. You wouldn't have an increased risk of cancers because of HRT. After 50, you can then decide whether you would like to continue or not, depending on the situation, depending on whether you would like to have more symptom relief, how your bones and your heart parameters look like. But certainly in the limited information I have here, HRT would be actually more beneficial than any risks for you at this point.
So I've quite a few questions on, I'm in my early 50s, I'm already 52, but starting to having changes in my periods and feeling joint pain. Would it be safe to start at my age? So there are a couple of questions on women in their early 50s.
So again, late 40s, early 50s, right up to the age of 55, 60, you can still consider starting HRT. Benefits would outweigh risks for majority of women.
Thank you. Another question is, can we give HRT in case of meningioma?
Meningiomas are brain tumors which can respond to progesterone. So estrogen is not a problem. But if you have a uterus and you need HRT as estrogen with progesterone, then that one has to be careful about it, because progestogens, the synthetic ones, like the cyproterone or the synthetic ones like medroxyprogesterone, norethisterone, they can contribute to growth of meningioma. A recent study in BMJ did suggest that a natural progesterone did not seem to increase the risk. Similarly, a Mirena coil or a levonorgestrel coil did not seem to affect the risk of increase in size of the meningioma. So first, try non-HRT options. And if you have to take HRT, one would combine estrogen with either micronized progesterone or a Mirena coil. And it's important you're looked after by your neurology team so that they can do frequent monitoring, imaging of the meningioma if it's still there, that it doesn't increase rapidly in size.
Thank you, doctor. One question is, can you please ask doctor about women that don't absorb very easily? Tried various patches and gels, it didn't work.
So it's possible. Everyone has a different absorption threshold. You can have two women exactly with the same age, same BMI, and the same medical factors. One doesn't absorb patches, but absorbs gels. The other person doesn't absorb the gel, but absorbs the patch. So everyone's skin receptors are different. Everyone is built differently, metabolizes medication slightly differently. So when you don't absorb, it is possible that you don't absorb a lot of preparation. So it's worth trying gel, spray, patch, oral. And if that doesn't happen, you'll usually find one of these four in a high dose will usually work within the licensed dose. If none of these four routes of administration work, you can then opt for implants, which can often usually be pellets under the skin. And these are the last option, which usually works if the other forms of absorption do not work.
Thank you, doctor. So, a couple of questions on doctor. I'm 47 years old. My periods are regular. I have joint pains and sleep issues. Do I need to go for hormonal tests? Am I in perimenopause?
We do not recommend blood tests for management of perimenopause. Menopause, if you're about the age of 45, because the levels will vary on a day-to-day basis. I might do a blood test for you today and see low levels, and it'll be next day or next week, it'll be normal. So the time when I catch you to do the blood test will determine the result I get. So they're not very useful to determine whether you should or should not have HRT. If you're above 45, still having periods, but having symptoms such as lack of sleep, joint pains, that does suggest lack of estrogen on the fluctuating basis. You could certainly consider HRT straight away without having to do blood tests.
Thank you. Another question is, I'm 46 years old with no specific symptoms and diagnosed with perimenopause. I've been prescribed evening primrose. Is it effective?
Honest answer is no. So again, evening primrose oil is something which is recommended if women have breast tenderness, breast pain, on estrogen type of treatments or HRT. Generally standalone as a treatment of menopausal symptoms. Most women do not report enough symptom relief, and therefore one would say it's not recommended as a medical option.
Thank you, doctor. Now, another question. I've had SVT 20 years ago. Should I consider non-HRT options or should I consider both?
You can consider both because remember that HRT is not mandatory. You don't have to always take HRT. If you can maintain lifestyle, non-HRT options or therapies that give you quality of life, and you're looking after your long-term bone and heart health with good lifestyle, then you can wait on HRT. However, if you're suffering from symptoms in lifestyle and non-HRT is not working, you would like better quality of life, then even with the SVT, you can safely consider transdermal forms of HRT. You have to be supervised to make sure that you stay on low doses, and your cardiologist would be very useful to have a joint decision in this particular situation.
Thank you, Doctor. Doctor, are there any recent advancements on new treatments in hormonal replacement therapy that we should know about?
These are the ones I talked about in my slides today. So you've got the body identical natural progesterone, which is now available, and the dydrogesterone, the two progesterones, which are far superior and far safer than the old 20 years ago WHI forms of the progestogen. You have estrogen as spray patch gel, which doesn't increase risk of blood clotting and is very safe. Again, this wasn't available to us 20 years ago easily. You've got testosterone, which certainly helps with libido, which is an addition for some women, especially following surgical menopause. You've got non-HRT medication, the NK3 receptor antagonist now, which is the breakthrough medication that was licensed this year in the UK and hopefully will be available worldwide by next year. That's another fascinating new development in the menopause area.
Thank you, Doctor. Another question. Doctor, I have symptoms. I am 48. However, my GP is reluctant to prescribe HRT for me. What should I do?
To the that you're setting to 45, usually HR can be prescribed for menopause symptoms to have blood test that. So these are the arguments you might want to have. And if they're not confident or would not prescribe to you, ask for a opinion to a specialist clinic who deals with menopause and HR.
So I think, Doctor, I think your internet is a little weak, I think, because we couldn't hear. I think, sorry, I think Doctor has dropped off. So just let's give him a minute. He will come right back on.
What happened there? I think some internet issue.
Yes, we were rejoicing that someone in the UK got booted off and India still is there. So, Doctor, one question that has been coming is, as a co-iliac, I have trouble absorbing. I use patches and testosterone, but I'm still very symptomatic. Could it be due to co-iliac disease?
Celiac. So again, it's a celiac disease. So basically, there's some gut issue here, and oral HRT usually wouldn't be recommended. But again, remember, you have a choice between patches, gel, sprays for estrogen. You have a choice of testosterone, either as a cream or a gel. And that depends on usually whether you're seeking a private consultation in the UK, for example, or you're through the National Health Service. But you have a few options you can try on. You may not be absorbing the patches enough, and you might want to swap to another route. So do talk to your GP or your hormone specialist, because they will be able to make sure you're absorbing enough from your current HRT and then correlate that with your symptoms.
Thank you, Doctor. Question is, I am 60 and experiencing symptoms. Can I start HRT?
Yes, this is a good question, because the question often is how late can you start HRT? Now, generally, if you've had no symptoms after the initial transition between, say, 45 to 55, you've not had menopausal symptoms, and you're now starting to experience some of the symptoms at 60, one questions first is this hormone-linked symptom? Because you've never had them for last 10 or 15 years. And to have hormone-linked symptoms coming up for the first time around this age of 60, 65 is unusual. So you must make sure that you've had all the other checks to rule out that these symptoms are not overlapping with some other condition. And again, after 60, one can start HRT. It's not contraindicated, but the benefits for bone and heart may not be as much as starting it earlier in the, say, 50s or 40s. If the symptoms genuinely do appear hormonal, then you can still have low-dose transdermal HRT and the natural progesterone. But remember, the benefits are not as much as before, and you have to take on board the risk of the breast cancer. Again, the risk is not unduly high, but we don't have good data for women in 60s and 70s. for the long-term risk. So it's important you take that information on board and then start HRT after 60.
Thank you, doctor. A couple of questions on magnesium and HRT. Is there any link to the two, magnesium and HRT?
There are some reports that magnesium or a few other supplements can reduce efficacy of HRT and vice versa, that you have to be careful what time you take them, but there are no concrete scientific data here. Magnesium can help alongside HRT for sleep. So some women feel that including magnesium in their supplement can help with sleep. Again, data are conflicting. Good, robust studies don't show that evidence. And so often, because magnesium is harmless, taken in the normal sort of doses included in supplements, we say that you can try it for sleep, but if it doesn't work, then you can stop. So you can take it, but there's no scientific evidence that in one way or the other, it will harm you or benefit you.
Thank you, doctor. Does your weight affect the way you absorb HRT?
We have no evidence of that. So BMI or weight or how much subcutaneous fat you have under the skin, we don't have evidence how it peculiarly affects absorption for every individual. Again, as I said, two individuals can be exactly the same and have completely different absorption through gels, patches, or spray. So for you, it's unique. As long as you try different ones that suit you and find the one that works for you, that is the key. Comparison is not shown to that there's a particular factor that affects absorption.
A follow-up to that, I exercise and it seems I need a higher dose of estrogen. Does exercise mean that you metabolize estrogen quicker? So will I need a higher dose?
Again, there is no conclusive link between how much you exercise and the link. Exercise is very good for bones, heart, as well as for many metabolic processes. Whether you do more exercise or less exercise doesn't actually correlate well with the dose of HRT. The dose of HRT will depend on your symptoms. I wouldn't go down the route of blood testing and absorption testing, more by your symptoms. As long as your symptoms are getting controlled by the HRT gel, spray, or patch, then that's what matters. If you've gone to the highest licensed dose and still it doesn't work, then that's when you do bloods to know the absorption. But generally, it's the symptoms that you will go by, and levels of exercise won't make the difference to the dose of HRT.
Thank you, doctor. Do we need to monitor breast and vaginal ultrasound after starting HRT? If yes, how often?
No, so current recommendations don't give you any extra work in terms of monitoring for pelvic ultrasound or in terms of breast ultrasounds. What we do in UK here is we have mammograms every 3 years between the age of 50 to 70. So you'll have a mammogram every 3 years. And plus, we also ask women to check their breasts regularly, self-breast examination in case they see any changes. That's just general screening for every woman, whether you're on HRT or not on HRT. There's no extra monitoring that we recommend in terms of HRT.
Thank you, doctor. Doctor, are there any side effects with HRT? And if so, what strategies can we use to... Yeah, sorry. Go ahead, doctor.
So again, I think we talked about them in my slides. So side effects can be headaches, a bit of irregular bleeding. You can have nausea. You can have a little bit of breast tenderness or pain, bloating, a bit of drop in mood. These are typical effects of estrogen progestogens, which happen in the first 2 to 3 months of starting HRT. Most of them will pass away on their own. If you have persistent bleeding or persistent symptoms, which we described, you can reduce the dose of hormones and take it more gradually. Increase them more gradually over the next 6 or 12 months. That way the symptoms or the side effects won't return. If you have bleeding beyond 6 months on HRT, then of course we recommend a scan, and then a slight adjustment of the dose of hormones should take away the bleeding.
Thank you, doctor. And I think we are going to come to an end. How does HRT affect mental health and cognitive functions during menopause?
It does, because remember, the lack of estrogen, the fluctuations, they trigger symptoms such as the poor memory, the brain fogging, the cognitive difficulties. If you take HRT, it does smoothen that out. Most women will report better cognitive effects, less brain fogging, they can concentrate better, their memory improves. These are short-term effects. This does not mean that you have risk of dementia. These are two different aspects. The cognitive symptoms, so the brain fogging that happens during perimenopause, menopause, is because of the fluctuation. So if you give hormone back, you'll try to take care of that. Dementia risk is something that happens in older age. That depends on your lifestyle. There are medical factors, so many things. And so really important to keep your lifestyle good for prevention of dementia. Right now, we don't have evidence that HRT prevents dementia. There's a lot on the internet you can find saying that, but we need concrete good studies to prove that. There are specific groups of women, like those who have some genes who may be at risk of dementia, who may benefit from HRT. But women with natural menopause, it's lifestyle which is more critical than just HRT for dementia.
Thank you so much, Doctor. So some of the ladies have asked very technical and medically oriented questions, which I've avoided asking because, as you said, Dr. V, that, on a webinar, you cannot,
Yes.
without seeing their records, you cannot. So some of the ladies, if I have not asked a question, please do excuse us. This is on doctor's request that I didn't ask it here. Doctor, I think it's time, we've spent an hour and 15 minutes and it's gone so
Yes.
fast. I know you have a very busy day in London today. So just to give a vote of thanks, we have Dr. Maya Modi, who herself is a very, very respected gynecologist and a big proponent of, various treatments for, care around perimenopause, menopause. And she doesn't shy away from HRT. And she's actually our mainstay in our community and like a backbone to all of us. So Dr. Maya Modi, if you can just give a vote of thanks. Thank you so much.
Thank you, Dr. Vikram Talaulikar. It was very good to have you, and you really simplified the matter. I think everyone has understood very well. And it is, we know that HRT should be used, and you have to outweigh the risks. That's the one thing. And it is quite safe, knowing after the medical history and examination, we don't need a blood test. And I would say we have sprays, gels, and patches in Baroda, also Gujarat. So they are available. We have the Lenzetto spray also. It's been recently come since, I think, a year or so it's available. And it's a very good thing. And people should learn way, but please don't use it by yourself. Please take help of a gynecologist. And we have even the menopause doctors from there you should take. Here, most of the GPs do not prescribe this thing, HRT. So that is the difference. So it is good to have everyone here. And it is good to have the Sanjeet Shetty, who is the CEO of Miror, who has put this platform in use. And so many women have joined all over the world. I wouldn't say India, all over the world. And so it is very good to have you. And he is constantly in touch with this subject. I'm very grateful. Like a man being so much touch into this perimenopause and menopause is a great thing. Thank you, Sanjeet, very much. I'm very glad to have you here. And it's glad to have been with Miror. Just started a few months, but I really enjoy the work. And I think Dr. Vikram has really simplified the matter. HRT can be used below the age of 60. That's the norms. Usually it is the norm. We should not use it above. But, I just wanted to ask you one thing, Vikram. I had a patient. She's like 71. She was hysterectomized at 68 years. Panhysterectomy. Suspecting cancer or something. And she has a little bit of family history of breast cancer. And cancers, different. So she was prescribed Lenzetto spray. I don't know whether it should be used or not.
Generally, I wouldn't recommend somebody after 70 because if they've already had menopause a few years or at least a decade back, then it would be very limited role for hormones. Yes. So it would be very limited role for hormones now. HRT is a treatment for menopausal symptoms, during perimenopause, menopause. And so really, I would question the use of Lenzetto in that setting. You probably would be much better considering non-HRT and lifestyle options for that person.
Thank you.
No, that has already been done. She was having a lot of hot flushes. And she was having breast tenderness and sleep disturbances. But now she's fine. As you say, like we do not recommend and it's not really to be used. So thank you for your good work.
I think the message there is get the benefits right. The message there is really, we neither want underuse of HRT, deny it for people who really need it and will benefit from it. But we also don't want abuse or overuse, which can sometimes happen, as you rightly said, unless it's properly medically supervised. So that's really equally important safety message.
Well,
Okay, please get the message, all of the ladies, and you can use it, but provided you really need it. So thank you very much. Thank you,
Thank you.
Miror. Thank you, Dr. Vikram. We have you here. Thank you.
Thank you,
thank you,
Sanjeev.
Dr. Vikram. Thank you. Thank you, all the ladies who made time on a Saturday evening, India time. Thank you. I hope you've gained, and we'll have many more sessions with and thank you, Dr. Vikram. Thank you. I know it's the middle of a
Thank you.
working day
Pleasure.
and you made time. Thank you once again. Thank you.
Thank you,
all.
everyone. Bye-bye.
Bye-bye.
Thank you. Thank you all.
Thank you, Dr. Maya.